Okay, we're going to continue our talk on chapter 12 for week 8. So let's talk about the current diagnostic system, which we use the DSM 5. So this was first published in 1952 by the American Psychiatric Association. So they developed and published the DSM 5. The most current publication, so it's in its 5th edition, the DSM-5 was published in 2013. Um, Psychological disorders are organized into 20 categories, and there are approximately 300 disorders listed. Now, the DSM-4 had 17 categories, so some of the disorders that were placed under one category, they've sort of split those up, so there's a few more categories now. But this is atheoreticals, which basically means it doesn't rely on a specific approach. It's just descriptive of the psychological disorder itself, the symptoms, and the symptoms that are associated with it. Okay, so it's a descriptive approach, and it is used at large within the medical community when defining or when diagnosing people with psychological disorders. So I've listed all of the categories here with some examples. So we have neurodevelopmental disorders. So these are things like intellectual disabilities, okay, autism, ADHD or ADD. So these are intellectual disorders, neurodevelopmental. Schizophrenia spectrum is sort of in its own category along with other psychotic disorders. So schizophrenia is the main one, but basically any disorder that would result in um, perhaps hallucinations or hearing voices, and so on and so forth. The third category is bipolar and related disorders. So again, this is bipolar disorder. That is the most associated one in this category. We have depressive disorders and anxiety disorders. So you have major depressive disorder, social anxiety disorder. And then, of course, we have obsessive compulsive disorders and related disorders to that. So OCD and hoarding disorders are included in this category as well. There are trauma and stress related disorders, so PTSD, dissociative disorder. So this is multiple personalities is what a lot of people know this as, but it's actually termed dissociative identity disorder. The somatic symptom disorders, so these are things like anorexia, binge eating, and so on. There are eliminating disorders, so nocturnal enuresis, which basically means bedwetting. So if it's prevalent and reoccurring for many, many years, then it is considered to be a disorder. Of course, children wet the bed all the time when they're young or when they're potty training, but we're talking about this behavior occurring over a long period of time and occurring almost nightly in order for it to be considered in the DSM-5 as a disorder. There are sleep-wake disorders, so insomnia, obstructive sleep disorder, so that's basically when you sleep, but you might sleepwalk or things like that, or sleep talk, right? To the point where you're not getting good sleep, you're not resting, okay? Paraphilic disorders, so this is pedophilia, masochism disorder, so those are also defined within the DSM-5, and a number of other categories. So sexual dysfunctions, that's like erectile dysfunction. We have disruptive impulsive control, substance related and addictive disorders, so that's alcohol use, gambling is included there, drug use. The neurocognitive disorders, so you have things like Alzheimer's, Parkinson's, Huntington's disease. You have the personality disorders, and then there is the last category is other mental disorders. So these are maybe symptoms that are characteristic of a mental disorder, but they don't necessarily correspond to the criteria for any other mental disorder. So it's sort of like the miscellaneous category, I would say. So it's maybe someone definitely engages in behavior we would term as abnormal, They might show signs of distress or anxiety, but it doesn't fit into any of the specific categories because each of those categories, they have very specific structured um, measures for the behaviors, right? So when we're talking about something like alcohol use disorder, that's defined as how many drinks they have in a day. They're dependent on that. They're addicted to it, right? Like they would have to go into some sort of detox. So that's it's very well defined and laid out. So there are other disorders that don't fit any of those categories. So one example of this would be agoraphobia. For those of you who don't know what this is an extreme or irrational fear of open and public spaces. So this is when people, it can get so bad that they don't leave their home, right? They may not even go outside of their home. So maybe not even in their own backyard or their own front yard. So this phobia can become so impairing to the individual that they cannot even leave their home. When we look at the prevalence of this disorder, every year approximately 1.7% of adolescents and adults are diagnosed with this. So again, this is sort of falls into that miscellaneous category where it doesn't fit any of the other specific disorders, but it is certainly considered a psychological disorder, right? And females are twice as likely to experience this disorder as males are. And here is the diagnostic criteria for this that you can see. So there's a marked fear in 2 of the 5 situations. So you can see it gets very specific. And when they're talking about any psychological disorder and the way it's defined in the DSM-5, they're all this specific, right? So you have to meet certain criteria to be diagnosed with this disorder. Um, our agoraphobic situations are actively avoided. The fear anxiety is persistent, typically lasting for 6 months or more. And then at the bottom, you'll see a little note there that agoraphobia is diagnosed in irrespective of the presence of a panic disorder. So often individuals will have panic attacks if they are made to leave the home or made to be in situations where they don't want to be in large crowds or wide open areas. But what this is saying is that agoraphobia is separate. And then there's also a panic disorder that if they meet all of the criteria for the panic disorder, they would also be diagnosed with that. So they would have a comorbid diagnosis. Okay. Now, of course, there are some good things about diagnosis and having a diagnosis, right? So it facilitates communication first and foremost. So talking to a doctor about this or talking to others about this. And once you have a diagnosis, there's sort of this peace of mind that you can identify what it is that is wrong, right? Many times individuals will say, I don't know what's wrong with me. And when they have a diagnosis, it sort of gives them, something to sort of, define it by. It's hard when you're experiencing all of these sometimes very extreme, drastic feelings that you don't know what's going on, right? So it does facilitate communication. It, of course, promotes research on diagnostic features, the etiology of the disorders, the various treatments that are available, and whether or not they work. So, of course, the more individuals who go into treatment for these disorders, the more um, data we have on which treatments work and for what individuals. And like I sort of mentioned before, it can bring relief to clients. And they're also usually aware that others have the same problem, right? So they usually, once they have a diagnosis, they'll either join a group, especially people with like addiction, those disorders, and OCD, hoarding, panic disorders, agoraphobia. There are often groups that they will go to sort of help. That's part of the treatment. And so they meet others who are also suffering with the same disorder. And it can bring relief in that sense to know that they're not alone, right? That they're not the only one experiencing this. There are some negative aspects to diagnosis, and just I would say things to consider, right? Um, as with anything, nothing's perfect, right? There are issues with reliability, and we've seen this across a number of disorders and various diagnoses. The repeatability of the diagnosis is not always great. So, what does that mean? That basically means that interrater reliability, sorry, tongue twister, isn't great, which means that it's hard to get more than one clinician to agree on the same diagnosis. Okay, that doesn't always happen. So, and you've probably heard, if you haven't experienced this yourself, I know I have experienced this personally, but you may have friends who've experienced this where they go to one doctor who says, okay, this is what's wrong. But then when they see another doctor, they say, "Oh no, that's not it. It's this." And then maybe they go to a psychiatrist and they say, "Oh no, it's not that. It's this." Right. So you don't have a lot of reliability in the sense that the diagnoses don't match. Right. There was actually a study done back in 1962. They looked at the reliability of the DSM-1 category. So when the DSM first came out, the reliability then ranged from about 38 to 63%. And today it still averages between, around 50 to 60%. So it's better every time the new DSM-5 comes out and the categories are slightly restructured, the definitions and the criteria are fleshed out a little bit more. As we get more and more data from people being treated, that helps. So reliability is getting better, but you do still see this across medical professionals where they don't always agree on the diagnosis, which can be problematic and distressing to the patient. You can also have comorbidity, of course, which is two diagnoses, right? And often with psychological disorders, there usually isn't just one, right? But that can be missed. So you might be diagnosed with one thing and not diagnosed with the other that you're also experiencing. With diagnoses comes a stigma, right? A label, and it's getting better. Back in the 50s, which wasn't that long ago, but 50s, 60s, even 70s, people did not talk about this. If you were on any kind of medication, you certainly didn't speak about it. Um, and a lot of things were diagnosed as a psychological disorder that in fact weren't. One case in point is postpartum depression, right? So that was treated as sort of, now that is a condition, absolutely, right? Women experience this to a great degree. I did with both of my children, and I got help, and everything was fine. But back then, they sort of just said, "Oh, that's just women," right? Um, and or women would try to hide it because if they actually came forward to doctors would actually diagnose them as being insane, right? So some of the behaviors that are associated with postpartum depression aren't great. And they can be quite dangerous if you don't seek help and get treatment. And so if women were coming forward at that time, back in the 50s and 60s and saying, these are the things I'm experiencing, they would actually be diagnosed as being quote unquote crazy, right? So there's this sort of stigma that just lingers a little bit from that time when people just, they didn't see being diagnosed with a psychological disorder as a good thing. I think now we're looking on it more favorably that if you get help and you get treatment so that you can function in your daily life, that's a good thing, right? That's not something to look down upon. Um, it is not something that is shameful. You are recognizing that there is something possibly chemically in your body going on, or even if it's just environmental or from experiences you've had in the past, there's something wrong and you need help and you need treatment, and that's okay. That's a good thing. And so the stigma is starting to go away, but it is certainly still there. And then, of course, a number of disorders included in DSM, they have increased over the years. So there are critics who would say that a lot of medical problems are now being included as psychological disorders where they shouldn't be. So things like sleep apnea, right? That is more of a physical medical problem and not a psychological disorder. So just some things to keep in mind when we're talking about diagnosis of these things. And then we have classification and diagnosis. So, if we had a perfect system, right? If we could design the perfect system, we would hope that um, we could classify disorders by presenting signs and symptoms. We would use the etiology and history of the disorder, the prognosis, and response to treatment. So we would use all of those things when classifying and diagnosing a patient with a certain psychological disorder. We could identify different symptom clusters that accurately signal different disorders, and there would be no overlap between symptoms or signs between disorders. So, this is basically saying we would be able to pinpoint each individual's symptom and match that with a very specific disorder, right? Or sign of the disorder. And then we would be able to identify precise and effective treatments for each individual. Now, of course, this would be an ideal perfect world, and that doesn't typically happen. But that is the goal, right? And every time the new DSM-5 comes out, every time they recategorize things, every time they come up with new definitions, that is what they're trying to do, right? They're trying to get the system to a place where we can have high inter-rater reliability, right? Where we do see a consistency in diagnoses across medical professionals. And when we have better definitions and better flushing out of these disorders and the symptoms that are seen along with it, we will increase those rates over time.